I'm going to start slowly with housekeeping while people continue to filter in. And Sarah, if you would be able to advance the slides, please. Thank you so much. I'll start with our land acknowledgement. And we acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. The Medify program is located in Toronto, on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawandarons. This is Dish with One Spoon Treaty Territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. And I invite you, all of our partners, to reflect on the territories where you are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Thank you. It is our hope that Elder Teresa Fiddler will join us shortly to open the conference and bring greetings. We'll move forward for the moment and welcome her whenever she can join us. So that gives me a chance to move straight into thanking the conference planning committee who provided such great guidance in selecting topics and speakers to make this another great conference. As is fitting for a conference that draws a diverse audience of service providers, researchers, administrators, and community members, our committee includes people with lived experience of accessing substance use supports and a variety of types of clinical expertise from across the province. And we're really grateful to them. If you could move to the next slide, please. So in addition to thanking them, I have to do a quick run through of disclosures and conflicts in order to meet our accreditation criteria. So everyone is listed here. Next slide, please. 2 members of our scientific planning committee have received honoraria from Indivior for speaking engagements or participation in an advisory board capacity, and any potential sources of conflict of bias have been mitigated by the participation of the full SPC in the planning of the conference content. Next slide, please. And lastly, this program has received financial support from the Ministry of Health in the form of base funding and in-kind support from Women's College Hospital in the form of infrastructure. Okay, before we move into content. Over the last several years, we have seen significant shifts in the substance use health landscape. Increasing numbers of addiction medicine consult teams, involvement of nurse practitioners throughout the system, more education in substance use, in nursing and medical training, and investment in programs intended to create standards of care for people, utilizing many parts of the system. But we've also experienced a retraction of support for harm reduction with the closures of supervised consumption sites and safer supply programs. Most recently, as the unregulated drug supply continues to change, we're seeing the impact of medetomidine on people who use opioids. These transitions, among others, create an environment of uncertainty where guidelines and best practices often lag behind emerging evidence, and clinical expertise is developed through sharing observations and strategies. This is the context in which the ability to make connections strengthens our ability to provide high-quality care for people who use substances. There are many examples of these connections between healthcare professionals, between clinicians and peers, between providers in different healthcare settings, clinicians and researchers, researchers and policymakers, care providers and funders. So it's in that spirit that we set the theme of this conference, and that I turn the mic over to Dr. Kahan, Medify's medical director, and then to Kate Hardy, our network director, 2 people who continuously demonstrate the power of connections and collaboration in their quest to achieve Medify's vision of integrated, appropriate, low barrier, and equitable healthcare for people who use substances. So although Mel doesn't need much introduction, I will briefly say he is currently the medical director of Medify. Dr. Kahan has written a number of peer-reviewed articles on addiction and has been a principal or co-principal investigator on several randomized trials and observational studies. To say he has been extensively involved in policy and advocacy is an understatement. He has helped write many guidelines on opioid agonist treatment, opioid prescribing for chronic pain, and has co-authored several handbooks and guidance documents. And he has a strong interest in the integration of addiction medicine into primary care, emergency departments, and hospital units. And he has 5 grandchildren who like to remind him how old and slow he is. Says. I may just introduce Kate at the same time so that we can move from one presentation to another. Kate, who is an MSW, RSW, Master of Health Science, is the network director of the Medify program. She's worked at Women's College Hospital since 2013 and helped found the Medify program in 2015. As director of Medify, Kate liaises with provincial agencies and raises the profile of the rapid access care model, which has been adopted by over 70 clinics. No, well over that. This is an old bio. Over 90 plus clinics in Ontario, in addition to clinics in other provinces. Thank you, Mel and Kate.
Thank you so much, Jennifer, for the lovely introduction. I'm going to give a really quick overview of my perspective on some of the issues of facing addiction treatment in Ontario. This is my individual perspective. I'm certainly not looking at the entire addiction treatment system, just some selected parts of it. Next slide. Start off with heart hubs. And I want it for each component, I'm going to talk about the challenges and opportunities. The biggest challenge, I think, facing heart hubs is that funding has not established a central service under one roof. I think that would be really what's needed. So a patient who is a person who is homeless and has substance use problems should have one place they can go to where they can get clinical services and social services right under that one roof, rather than being sent off to different places. So that's one challenge, I think, with heart hubs. The other is that the services that are funded by heart hubs are constrained by these these funding agreements that they have, which have been set up by the ministry. One of the agreements is a ban on what they call needle exchange programs, or NAPs, and that has created real problems. The opportunities are that heart hubs have a mandate to fund addiction treatment services. That's part of what they're supposed to do, and they have the funds to do it. So treatment services should or have the opportunity to advocate within heart hubs for appropriate funding to make sure that they can provide good care, and also that they have a pathway with other partner services to connect patients back and forth. And furthermore, RAM clinics and withdrawal management services should be careful in their interpretation of the funding agreement. That's critically important. These programs, RAM clinics, do not provide needle exchange programs. That's a formal program. That's not what RAM clinics or WMS do. They hand out clean needles to clients and inhalation equipment to clients as part of a clinical encounter. So they're not going against any funding agreement with that. Next slide. Supervised consumption site closures. I think we're all aware that this has puts patients or clients at risk because they don't have a safe place to inject where they can be revived if necessary, and it's supervised. The other thing that is maybe less discussed is that supervised consumption sites were very important places for people to not just to use drugs, but to get acute care, to get medical care, to get support and counseling, connection to other services, amenities like food, etc., and a sense of community. This was their one home, so to speak, that they could go to meet other people, to get wound care, etc. So these clients will become, many of them will become disengaged from health services and will be at risk for overdose. So it's not just that they don't have a place to use, but they don't have any connection to the system. So I think that the heart hubs, which fund or oversee many of the supervised consumption sites, should work to establish clinics or services that meet the needs of former SCS clients other than supervising their drug use. And that includes distribution of naloxone and injection supplies, wound care, antibiotics, opiate agonist treatment on site. And these clinics should be on the site of the old SCS and have extended hours and give people a space to congregate and provide amenities. So that's what I would hope to see with the closure of these sites. Next slide. RAM clinics. As we all know, many RAM clinics have limited drop-in hours where both a counselor and prescriber are present due to lack of funding and due to difficulty recruiting addiction physicians and addiction nurse practitioners. And also, RAM clinics are supposed to be part of an integrated care pathway linking emergency department, withdrawal management, primary care, other addiction services, and psychiatry. Often there are troubles with that system of lack of access of RAM clients to other services. Opportunities, the Mental Health and Addiction Center of Excellence is completing a comprehensive review of RAM clinics and expected to recommend enhanced funding to support their recommendations. The Center of Excellence will be releasing these RAM clinic sector expectations, which are very consistent with our own targets document. And Medify has worked closely with them to set that up. So we're hopeful for the future in terms of increased funding. Next slide. Withdrawal management services. Many WMS are not adequately staffed by nurses and NPs, and that makes it difficult to ensure medication-assisted treatment for withdrawal and for initiating opiate agonist treatment, etc. Nurse practitioners and nurses often have to deal with complex clinical situations with little backup or support from physicians and the healthcare system in general. The opportunities, though, theoretically, are enormous. With appropriate funding and staffing, withdrawal management services would treat withdrawal, would initiate opiate agonist treatment and anti-craving medications, and connect patients to RAM clinics and other services. And that would greatly improve patient outcomes and reduce the burden on the emergency departments and hospitals and strengthen the integrated care pathway. Next slide. Emergency departments and hospitals. Many EDs and hospitals do not have addiction consult services and do not initiate medication-assisted treatment on site, even though the evidence suggests that doing so greatly improves treatment engagement and retention. The opportunities, the Center of Excellence is funding an integrated care pathway initiative in which EDs will provide evidence-based treatment of withdrawal and opiate agonist treatment and anti-craving medications and connect them with RAM clinics. Medify has contributed to the development of these protocols and training materials. And as Jennifer mentioned, even locally, even aside from the Center of Excellence, addiction nurses and NPs and physicians and counselors and peers are strengthening hospital-based services in their local communities. Next slide. Primary care, a large proportion of substance using patients do not have a primary care provider, and many PCPs do not provide care for substance use disorders. It's clear that if a patient was stable on buprenorphine, for example, or on anti-craving medications, they would be better off in a primary care setting. They would get more comprehensive care. And that would free up the addiction treatment system to look after more unstable patients. So opportunities, there's collaborative care programs between RAM clinics and primary care. They show promise as a strategy to improve primary care capacity. And Medify is working on a primary care toolkit for release in early 2027. Next slide. This last thoughts, I would just say that even though, as Jennifer mentioned, the landscape is severe and in many ways worse than many years ago with the introduction of fentanyl and methamphetamine and crystal meth and all these other terrible things. But the sector itself has undergone radical transformation compared to 10 or 15 years ago, and it's far stronger. There's many innovative local initiatives, that we often don't even hear about. Many more communities have RAM clinics, hospital consult services, medication or medical withdrawal management services, and other services. More nurses practitioners, many more RNs, peer workers, and other healthcare professionals are involved in addiction treatment. When I first started off, addiction involvement by physicians and nurses was strictly management of withdrawal. That's all we did. It's changed dramatically. There's an incredibly rapid innovation in clinical protocols and approaches. OAT, opiate agonist treatment, has changed more in a few years than in decades prior to that. And there's many more educational events and toolkits and guidance documents and work going on. Next slide. Personal reflection. I've retired a couple of years ago from clinical work. And I think there's no surprise in saying clinical work and addiction can be very stressful and sometimes heartbreaking, despite everyone's best efforts. Sometimes things don't work out for patients and terrible things happen. Often we work in isolation with inadequate compensation and support and recognition. So it's very challenging in that way, but also work in this field can be deeply rewarding because many patients recover. And when they recover, the recovery is profound. It's not just that they're feeling better, they're functioning better, their mood is better, they're just doing better overall. And they are deeply grateful for your role as a counselor or clinician in their recovery. So thank you. And now I'm going to turn it over to Kate.
Good morning, everyone. I'm Kate Hardy, and I'm the Network Director for the PHI program. Thank you so much for being here and welcome to this year's conference. I'm going to spend some time this morning just reviewing the past year for the PHI program and the impact we've had in collaboration with so many of our partners. As so many of you are aware, this past year has brought a rapidly evolving landscape. There are fewer harm reduction services and supply and support options available. And we are seeing an increasingly complex environment for our clients with a more unpredictable and toxic, unregulated drug supply. Within this pressure cooker situation, we're also facing growing pressure from within the healthcare system to continually do more with less resourcing. So the need now is greater than ever for a trusted and responsive provincial partner that provides timely support and guidance, that strengthens connections across the substance use sector, and enables shared learning opportunities, as well as driving coordinated action. So what does it mean to be a provincial partner in substance use care? Let me throw some stats at you to sort of illustrate what it means from the perspective of the PHI program. PHI supports 91 RAM clinics across Ontario, and our community of practice now has 1,500 members from across Ontario and beyond to across Canada and into the States. Our nurse practitioner community of practice has grown to 216 members. This is a place where NPs can come together to share and learn. We see 400 attendees at our annual conference. So hello, everyone, welcome. Our provincial advisory committee has 13 members representing all corners of the province. And this past year alone, we've had 45 different individuals contributing to our clinical guidance documents as working group members or reviewers. I'd now like to narrow in a little bit to use an example to illustrate what this actually looks like in practice. As both Jennifer and Mel touched on, unfortunately, we are seeing a surge of medetomidine in drug samples. I know this is hitting a number of communities across Ontario and certainly in Toronto, something that we are seeing. So what has Medify's response been to this? Well, firstly, we collaborated. We've engaged key partners, including Toronto Drug Checking Service, Public Health, and TOWIN. We've co-created, forming a multi-sector working group to develop 3 different clinical guidance documents to guide care in different clinical settings. And we're in the process of creating a client-facing resource in partnership with our community consultants. We've educated, hosting a pop-up webinar with 150 real-time attendees, and we've disseminated materials and updates through the Medify listserv and other communities of practice. The result has been a multifaceted and rapid response in partnership with our broad network of partners, clinicians, community members, and different programs. I'd like us to take a bit of a step back now and use a wider lens to review the key achievements for the Medify program from this past year. So the first achievement I'd like to touch on is leading RAM clinic quality and coordination efforts. This last year, Medify has supported the Center of Excellence in developing the provincial RAM clinic program expectations. And we've continued to advocate for appropriate funding to sustain and expand high-quality care delivered through the RAM clinic sector. We've also acted as a consultant to the Ministry of Health on their core services framework for the RAM clinic sector. And we published Medify's 2025 iteration of the RAM clinic quality targets. Alongside that, we delivered the annual provincial and regional RAM survey reports, which summarize the services available across the provincial RAM clinic network. We've continued our quarterly town halls and launched a new administrator listserv to support RAM clinic leadership. And as always, we've continued to provide ongoing education and mentorship for RAM clinic staff and clinicians via our monthly webinars, annual conference, listserv, and the nurse practitioner community of practice. The second achievement I'd like to touch on is advancing clinical practice across sectors. One of the elements of the program that I'm so proud of is the publication of our clinical guidance documents. And this past year, we published several key practice guidelines and materials to advance clinician knowledge and confidence. And this includes updating the withdrawal management toolkit. And this is a toolkit for providers working in the WMS sector, where they can access relevant information quickly and easily. We published methadone as opioid agonist therapy guidance for prescribers, which is an evidence-informed and consensus-based set of recommendations for prescribing methadone as OAT. And alongside that, published a plain language summary and quick notes for easy reference. And as touched on, we also produced a collection of rapid response medetomidine-related documents for ED, ambulatory, and WMS settings. All of these materials and hundreds of others can be accessed through the Medify website at no cost. The third and final achievement I wanted to cover today is fostering collaboration and community within the substance use field. Medify continues to support interprofessional and multi-sector connections via our working groups, community of practice, advisory committee, and our annual conference. And we've consulted and supported a variety of different sectors in their own journeys to provide improved and evidence-informed substance use care and education. RAM clinics will always be the cornerstone of the Medify program, but I'm so pleased that we've also expanded our partnerships this year. We've been working with paramedic services and heart hubs and continue to provide support and information to a variety of other sectors, including professional colleges, school of social workers and nurses, students in the social work, nursing, and medical fields, correctional services, health units, as well as a variety of different frontline clinical settings, including emergency departments and primary care. So pleased to share a little bit of what's next for the Medify program. In the coming year, in 26-27, we'll be releasing the Clinical Best Practices in Addiction Medicine, a guide for RAM clinicians, guidebook, and that will be coming in fall 2026. We'll also be releasing the primary care toolkit. It's a toolkit for primary care clinicians that will be coming out in next winter. We'll also be releasing the 2026 edition of the RAM Clinic Quality Targets document, coming in just a couple of months. And also, we'll be continuing our collaboration with the Center of Excellence to support the delivery of high quality care. I also want to take a moment to just talk about some of our ongoing advocacy efforts, because I think this work is so critical, especially now. We'll continue to work to increase RAM Clinic resourcing and operating hours, as well as expanding youth access to substance use care and expanding RN prescribing authority to include buprenorphine. We'll look to increase the availability and accessibility of harm reduction supplies, services, and education, which we all know is more important now than ever, and increase pharmacotherapy options that are available to service users across RAMs, hospital, primary care, and correctional settings through education and policy change. Before I hand things back to Jennifer, I just want to say a few thank yous, and I never get to do this in a public forum, so I am going to take just a moment with this. I must extend my sincerest thanks to my program team. Sarah Clark is our brilliant knowledge broker. As most of you know by now, she's also the muscle behind the annual conference. She does so much more beyond that, though. She is the lead on our quality targets for the RAM sector, our annual survey. She works on the majority of our guidance documents in varying capacities. We are so lucky to have her. Thank you, Sarah. Katie Dunham is our nursing educator, and she is a true national lead in nursing and NP education and advocacy work. Thank you so much, Katie. Dr. Meldon Kahan is our medical director for Medify. He's dedicated his entire career to advancing the substance use field and ensuring that it receives the recognition it deserves within the healthcare system. It would not be the field that it is today without his contributions and his championing it. So thank you, Mel. Lori Smith is our program admin coordinator. She keeps this entire ship afloat. We would all be lost without Lori. Simple as that. Thank you, Lori. And Dr. Jennifer Wyman is our clinical programs lead. She sets the vision for the entire conference. She also is the lead author on the majority of our clinical guidance documents. And I simply refuse to believe that she has the same 24 hours in the day that I do, given how incredibly productive she is. So thank you so much, Jennifer. I also need to thank our provincial advisory committee members who provide guidance and direction on so many of our programs, decisions and activities. Thank you to our scientific planning committee for the conference and monthly webinars. They review our abstract submissions, they set the agenda. Thank you everyone for your time. I'd like to thank our project working group members. As you heard earlier, there were 45 individuals contributing to our materials as working group members or reviewers in just this past year. Over the last decade, there have been surely hundreds. Thank you so much for your time and your expertise. Thank you to our community consultants for sharing your incredibly valuable knowledge and lived expertise and experience with us. You ensure that we continue to do better and be better. Thank you for sharing your time and, as I said, expertise with us. Thank you to our vast network of clinicians, staff, community members that all so generously share your knowledge through our many different platforms, our listserv, webinars, conference, and materials. We all gain so much information and knowledge through your contributions. So thank you for being so generous and giving that knowledge so freely. Lastly, thank you to our program sponsoring organizations, the Ministry of Health that funds the Medify program, and to our home base, Women's College Hospital in downtown Toronto. Thank you so much. I hope everyone has an incredible next couple of days at the conference. We'll look forward to continuing to chat and collaborate with you all.
Wow, thank you, Kate. That was quite the list of thank yous. So I wasn't quite prepared with the long list of things that that you do to acknowledge, really keeping us on track in so many ways. Thank you for being our fearless director. We will now transition into our keynote presentation for the conference, breaking down silos to build connections towards integrated health human resources in substance use care. Before I introduce our keynote presenter and we start the session, again, some reminders. The session is being recorded. If you have a question during the session, please enter it into the Q&A box and I will deliver it to the speaker once the presentation is over. You can add comments in the chat, but please make sure that, again, the questions go in the Q&A box. And remember that you can raise your hand if you'd like to pose your question directly. I am now very pleased to introduce our keynote speaker, Leigh Chapman. Named in 2023 as one of Maclean's top 10 healthcare innovators and as one of the 50 most influential Torontonians, Dr. Leigh Chapman is a leader within the field of nursing and healthcare. Leigh is a registered nurse with over 20 years of experience. Over the course of her career, Leigh has gained a deep understanding of nursing through her work in both frontline and clinical leadership capacities. Her professional experience spans various settings, including clinical care, addiction, education, research, professional practice, administration, policy, and advocacy. After obtaining her BSCN degree, Leigh completed a Master in Clinical Health Sciences from the Nursing Graduate Program at McMaster University. Leigh then completed her doctoral work in 2019 at the Lawrence S. Bloomberg Faculty of Nursing at University of Toronto. Her research provided key insights into ways in which the regulation of health professionals intersects with organizational priorities in acute care settings. As Chief Nursing Officer, Leigh recognizes the important contributions of nurses at the federal level and aims to ensure their integration into decisions impacting the profession. Within her role, Leigh provides strategic advice from a nursing perspective on priority policy and program areas. She plays a convening role with provincial and territorial governments, federal governments, regulatory bodies and colleges, educators, and others on key nursing issues. Additionally, Leigh represents the Government of Canada at public forums, both within and outside of Canada. Leigh is committed to advancing the nursing profession in Canada to ensure equitable access to safe, quality care for all. Thank you so much for being here today. We're really grateful.
Thank you so much for having me. I'm delighted to be here. And let me just pull up my slides. I do have to thank Medify because I was on deck to present the keynote last year. And as you know, we had a general election. And so that curtailed plans. So thank you very much. Merci beaucoup. My name is Leigh Chapman. I'm the Chief Nursing Officer with Health Canada. Je suis l'infirmière en chef à Santé Canada. And I hope we can explore together today how to break down these cross-sectoral silos. And specifically where substance use care sits at the intersection with perhaps health human resources as a bridge and integrated care as the goal. So I have no conflicts to declare. I will, though, state that in my previous roles that I've held, I was a member of the Toronto Overdose Prevention Society. I was also an executive board member with the Harm Reduction Nurses Association, and previously also employed at a community-based supervised consumption site in Toronto, which is now closed, as Dr. Kahan mentioned at the beginning. My family has also funded two harm reduction nursing awards and scholarships. One is national and one is provincial in Ontario. But those are all things that have either been done in the past or prior to my role as Chief Nursing Officer. AI was also not used in the preparation of this presentation, and I'm speaking to you today as a federal official. So these are some objectives for this session, and mainly I'll be focusing on the federal response and federal actions when it comes to the substance use workforce, as well as health workforce or health human resources. But I hope that we can achieve these outcomes with the presentation and certainly with some discussion that will follow. So I wanted to start with the scale of the crisis. When we look at the overdose crisis, the drug crisis in Canada, over the last 10 years, there's been more than 55,000 deaths. The majority, 88%, is for folks between the ages of 20 to 59. So these are people within their prime. Again, the majority is BC, Alberta, and Ontario, and majority is also male. When we look at the substances, the deaths are highest when fentanyl dominates. The supply is increasingly contaminated, as has been stated. We also can look at who is most impacted by this crisis, and it certainly is Black, Indigenous, racialized communities with unemployment or physically demanding trades being another risk factor. Housing or lack of housing, whether it's homelessness or insecure housing, and then health issues also being a key issue in terms of increased risk, as well as association with the criminal justice system, and in particular, recently incarcerated individuals. I think it's fair to also point out that when we look at the trends, we have substance use in general. So on the one side of the slide, substance use in Canada contributed to more than 200 lives per day in 2020. So a huge escalation that we saw over the course of the COVID-19 pandemic, with a significant economic burden of $49 billion. And the ongoing public health and economic burden has been sustained and significant. It is worth noting, though, that alcohol contributes to significant harm, and I think that's important to mention because it is, as you all know, a regulated substance. It's important to, of course, mention that substance use is linked to both mental and physical health outcomes, often contributing to or exacerbating conditions that require coordinated, integrated care across systems. And that's really what we're talking about today. So whether you look at the scale of the crisis from the perspective of mortality, morbidity, public health or population health, and that sort of epi data, or the economic burden, it's clear that it is a significant crisis impacting the health of people in Canada. For me, this is also a personal issue. I lost my older brother, Brad, in 2015. So this was before the Public Health Agency of Canada started tracking overdose deaths in 2016. And in 2018, there was a coroner's inquest in Ontario. He was 43 years old, had 3 children and grandchildren who he's never met. And so I think, regardless of your motivation for entering the field of substance use care, it's important to mention that no one is unscathed by loss in this field. So I do want to acknowledge that and thank you all for your continued work in this sector. So when we look at the federal, provincial, and territorial landscape, it's important to note the federal role as being fairly limited when it comes to health. We do, as you know, fund healthcare in Canada through transfer payments, but the responsibility for health lies to the provinces and territories. So the management, administration, and essentially the design of healthcare within particular jurisdictions, including regulation, education, training, and workforce planning, is entirely up to the provinces and territories. Health Canada does play a role when it comes to the health portfolio. In terms of development of standards, convening the various players, we do that in a variety of ways, notably the Committee on Health Workforce, which is a federal, provincial, territorial committee, and mental health and substance use committee as well, and providing sector-specific oversight and insight to inform broader government policy. ESDC has an important role to play, and a lot of the levers that they have are things like the Foreign Credential Recognition Program, which I'll talk a bit more about, looking at interjurisdictional mobility, and then administering the labor code for federally regulated workers. And this includes the labor market component of temporary foreign worker programs. IRCC has a role as well when it comes to the Immigration Act, which is a federal act looking at immigration policies. We are an immigrant nation, so ensuring that we actually have pathways for attracting talent. We have an international talent attraction strategy, and then looking at pre-arrival and settlement supports. So certainly the responsibility is broader than just Health Canada, but the role is fairly limited. And then my role in particular, so the bulk of my role, over 90% of my role, is nursing health workforce. And I think it is worth mentioning that Medify is a great exemplar because of the strong nursing leadership within Medify as an organization. So my role is to provide strategic advice, mainly on nursing health workforce issues. Federally, as I mentioned, we play a convening role. So I co-chair the Principal Nursing Advisors Task Force, which is comprised of every government chief nursing officer at the provincial or territorial level where they exist. Just a couple of jurisdictions don't have a government chief nursing officer, so they send a policy delegate. But then I've also convened the government departments that employ nurses. Which is also a very vast workforce, covering Correctional Services Canada, the Public Health Agency of Canada, Veterans Affairs, Canadian Armed Forces, RCMP, CSIS, and so on. So many federal departments where the work is vastly different, but they're all essentially federally employed nurses. I didn't mention Indigenous Services Canada as another important one. And then I represent the government both within Canada and internationally, although the majority of my work has been domestic since the time of my appointment. I started in this role 3.5 years ago in 2022. The role had been vacant for 11 years prior to me starting in the role. And I should mention that I am a federal public servant. So it is sometimes misleading when I say that I was appointed to the role. I'm not an elected official. I am a federal public servant. And it was a position that essentially I applied for. I'm the 7th chief nurse in the history of Canada since 1967. And because I'm a registered nurse from Ontario, I've been a registered nurse for 23 years now, I thought it was very important to prioritize engagement across the country. So I apologize for the quality of this photo, but it's a poster or display that says the war on disconnection. The opposite of addiction is connection. And I love this image. This is actually on reserve in Siksika Nation, which is Blackfoot territory just outside of Calgary. I've had the privilege of visiting nurses and connecting with nurses in every province and territory across the country. And Siksika Nation gets a special mention. One, because I love this poster, this image, but also they're quite remarkable in that they've transformed a former residential school into a community college. It's Old Sun Community College, and this spring they will be graduating their first cohort of Indigenous nursing students who learned on reserve. in a collaborative program with the University of Calgary. And this is Treaty 7 territory, which is really close to this location, was signed at Blackfoot Crossing. So it's a really significant place, and I think quite an inspiring community and nation. And so in all of my engagement, I have really prioritized speaking to frontline nurses, which includes those providing care in substance use. When we look at our workforce in Canada, it's important to sort of situate who it is that we're talking about. And there's particular elements when it comes to the regulated health workforce. We're looking at a legislated scope of practice, a protected title, mandatory education requirements, standards of practice, as well as a conduct process or enforcement process when those standards may be breached. So nursing is the majority. It's worth noting there's almost 500,000 nurses in Canada across the 4 categories of licensure. So we have licensed practical nurses or registered practical nurses if you're in Ontario, nurse practitioners. And nurse practitioners are rapidly growing, which I will talk about as well. Registered nurses are the majority, and registered psychiatric nurses are in every jurisdiction now in Canada, with the exception of Ontario. So previously, psychiatric nurses used to just be sort of Manitoba and West. They are now in the territories and now newly being licensed in the Atlantic region. As a result of a Atlantic feasibility study for psychiatric nurses. And physicians are almost 100,000 physicians in this country, but certainly lots of other professions that don't make it to the pie chart here. When we look at dental professionals across the many different dental professional categories, paramedics, pharmacy technicians, physician assistants, psychologists, psychotherapists, social workers, and so on. So the work is vastly different across these professions, but this is the bulk of our healthcare workforce. I mentioned nurse practitioners being the fastest growing health profession in Canada. They have more than doubled in recent years, and they are historically had been underutilized, but are increasingly being better integrated into our health systems. And this is a durable solution, not just to addressing the primary care gap, the 6 million or so people in Canada who are unattached to primary care, but also in providing specialized comprehensive care. Nurse practitioners are a key component of the substance use care workforce and have great expertise in this area. They can diagnose, they can prescribe, they can admit and discharge. There is very little that a nurse practitioner can't do when we think of the role in these settings. And I'll talk more about that at the end as well. But I really want to thank Dr. Wyman and Dr. Kahan for also mentioning the important roles that nurse practitioners play. Okay, so then when we look at the substance use workforce, it is there are many diverse providers providing care across the full continuum. It includes harm reduction, early identification, treatment, recovery, and this is, of course, occurring across a range of settings. There are core and integrated roles when we look at providers who work exclusively in substance use care, for example, nurses who are working in specialized clinics, as well as those who support individuals with substance use as part of their broader practice, such as a family physician or nurse practitioner. But importantly, the workforce is made up of both regulated professionals, as mentioned, physicians, pharmacists, nurses, nurse practitioners, as well as unregulated professionals, and each bring a distinct lens and essential contribution to care. And certainly, as a clinician, I've I had worked in this sector for a number of years prior to starting in my current role as Federal Chief Nursing Officer, and I've learned a great deal from peer workers and harm reduction workers, and it's actually really enriched my practice by working with people with lived and living experience and valuing that expertise. So when we look at our workforce, there's no question that there are inherent challenges, but the workforce is critical to a functioning health system. We don't actually have a health system without those who are actually providing skilled quality care, and the substance use care in particular across the continuum. And that means sometimes looking at across sectors that are very siloed when it comes to the way in which our health systems are constructed or created. We do have a shortage from a nursing perspective. We have a global shortage, as well as system fragmentation. And so that actually certainly is challenging for providers, but it's most challenging for those who are trying to access care when it comes to coordinating services and continuity of care. And these are long-standing challenges that require multifaceted action to address them by many parties. But it is worth noting that amidst these shortages, there are opportunities to optimize scopes of practice, to really look across the continuum and to try to knit the system together as best we can for the benefit of those we serve. As mentioned, provinces and territories have responsibility for healthcare planning and delivery. The federal levers are limited, but can be used, especially on the elected official side, to advance more coordinated, integrated approaches to strengthening the workforce. And then immigration is a vital component. I think it's worth noting that the key activities from a federal perspective include leveraging federal funding to drive action, convening the provinces and territories, and then also providing leadership on areas of federal responsibility, which includes immigration. And from a policy perspective, I'll just mention what this looks like in my world. So my three primary areas of focus include internationally educated nurses and their integration into our Canadian health workforce, nursing health workforce data, and mobility of nurses across the country, across jurisdictions. Some additional factors, just sort of digging a bit deeper into the challenges. In many ways, these challenges have been longstanding, but were exacerbated by COVID. And I would say we haven't recovered from the health system impact that we saw over the course of the pandemic. Due to the workforce challenges. Certainly when I started in the role in 2022, what was dominating the media was emergency department closures, really protracted wait times. This was a time when we had emerged from the duress of the pandemic, the first 2 years of the COVID-19 pandemic, and the workforce challenges were really getting center stage because there was a desire to return to business as usual of healthcare delivery, and that was constrained by the workforce challenges. So chronic supply shortages, these are especially acute in rural and remote parts of Canada, where the shortages don't just mean curtailing services, they actually mean closure of health services to entire communities, which is extremely challenging because it often requires medevacs or communities going without care. There's also been a loss of expertise. There was a mass exodus during the COVID-19 pandemic. We saw some early retirements, and so we have an increasingly novice workforce that needs the benefit of mentorship and expertise from experienced clinicians. There are barriers to timely mobility. I'll just hover on the mobility piece for a moment. We know that care occurs across jurisdictional borders. We've seen this certainly with virtual care, and it is very much an everyday occurrence in the territories where folks will come down to southern provinces to receive care. If somebody is providing care across jurisdictional borders, they need to be licensed or registered in that jurisdiction. So a lot of siloed policy and regulatory regimes. And that's also very common in the Atlantic region, where you just cross a bridge and you're in a different province, and often traverse these jurisdictional borders for care delivery. Foreign credential recognition has also been very cumbersome when it comes to the underutilization of health internationally educated health workers who are choosing Canada. We know that they're often facing a significant delay in getting their credentials recognized. And it's a very long immigration process, and then a long process as well for licensure. We've seen significant advancements, I would say, in recent years when it comes to foreign credential recognition in most professions. Often what occurs now is the difficulty in transitioning into the work environment, that navigation support that's needed. And then the lack of data. We have limited access to comparable, complete pan-Canadian data on health workforce. This became it really came to light during the pandemic because we weren't actually able to look across the entirety of the country to get a good snapshot of our health workforce. We don't have at present a standardization of national data sets. There are data collected by the Canadian Institutes for Health Information, as well as Health Workforce Canada, which we funded in 2023. But the data for some professions is quite limited. And planning, is fair to say, is misaligned with future healthcare needs. We have an aging demographic in Canada. We have increasing chronicity, as well as a demand for both home and residential or institutional long-term care. It is costly and time-consuming to train and educate health workers. And so thinking about how we actually iterate and evolve our educational curricula to best meet the future needs of our health systems. And that's always a challenge, perennial challenge. When we look at substance use workforce, this is even more complex. So fragmentation across the system remains a key barrier to care. Services across are often divided across physical, mental health, and substance use care. And that disconnect creates gaps in continuity, makes the navigation very difficult, especially when we think of the biopsychosocial impact of substance use care delivery. There are capacity pressures that we know that substance use care is not consistently integrated into broader health systems or policy planning. This is reflected in the limited integration of harm reduction into clinical care and underutilization of key providers. There are, and some of this has also been mentioned, but there are challenges identifying clear referral pathways in many cases, and this is particularly difficult for individuals with concurrent conditions. I often will say that people use drugs, have babies, need knee replacements, need to have their appendix removed, and we don't have a continuum of care, a substance use care across the entirety of our health systems. The current structure of the system is essentially contributing to this fragmentation. So much of substance use care is delivered across publicly regulated and community-based settings, which does create capacity constraints when it comes to system-wide oversight, coordination, and even visibility of services. We know that some of these things receive provincial or territorial as well as municipal funding, and some things are in the mental health or substance use care. Other is in housing, and so really looking at the complexity of the system. And we can't underestimate the perfect storm, where there's this complexity for patients and providers, but also stigma, the role that stigma plays. In addition to the workforce shortages that we've seen, stigma plays a significant role. Um, and often there are gaps in training. There's gaps in competencies, and I think Medify, being such a hub with such broad reach across the country, is really key in providing guidance and support. Ensuring consistency of some of that preparation to support substance use care, whether it's specialized services or primary care. So it's very clear that there are ongoing opportunities for collaboration to better support continuity of care. I think that there are some opportunities amidst the bleakness of the picture that I have just painted. So the health workforce is a bridge to linking these different sectors. We know that many clinicians work across a variety of settings, and it's a key lever for advancing more integrated substance use care. Primary care plays a critical role as an early access point. We know that primary care occurs in a variety of settings. It does create opportunities for that early intervention and responding to substance use needs before harms escalate. The workforce can serve as this connector across systems, linking social services and housing to support more continuous care, especially for individuals with complex needs. And there's also an important role, a prevention role, through responsible prescribing and approaches to pain management. We can also reduce substance-related harms. Health professionals play a critical role in addressing misinformation. This is a major concern of the Public Health Agency of Canada and our new Chief Public Health Officer, Dr. Wyman. But we know it's not just about access to information, it's also about trust, who delivers the message, how it's communicated. It does shape whether and how people will engage and how they will act. And so we have both a trusted position, a privilege, and also a responsibility by being well positioned to cut through the misinformation and support decision making. And as well, I think part of building trust is the way in which we're integrating people with living experience, as well as peer support workers, in strengthening engagement, trust, and effective outcomes. And we know that this involvement of people with lived and living experience has improved coordination across services. It's reduced recurrence and hospitalizations, supported treatment adherence, and housing stability. So this is a very busy slide, but I will break it down in terms of the federal actions on substance use. So this is guided by the Canadian Drugs and Substances Strategy, with a focus on saving lives and protecting the health and safety of Canadians. So the federal government works with the provinces and territories to expand life-saving services, which include these pillars of prevention, treatment, recovery, as well as protecting Canadians from illegal drugs and drug-related crimes. I'm sure you've all seen the work of the fentanyl czar in response to the claims from the United States that all of the fentanyl was coming through the Canadian border. So at the federal level, we act through a range of levers, including legislation and regulation, funding, research and data, national leadership, collaboration across jurisdictions with partners, and that convening power. And hope that together we can support and enable a coordinated evidence-driven response. So what does this look like in practice? These are things like national guidance, for example, in supporting standards, guidance, and tools. For example, the development of the opioid and alcohol use guidelines and tools to support integrated mental health and substance use into primary care, youth services, withdrawal management, and the development of the substance use workforce competencies for providers. We also have a regulatory role to play in expanding access to care, including new controlled drugs and substances regulation, which take effect in October of this year, and will allow pharmacists to extend and adapt prescriptions for controlled substances subject to requirements set out by particular provinces and territories and the laws and regulations inherent in those jurisdictions. Other class exemptions include enabling pharmacists and nurses to administer prescribed treatments, including injectable buprenorphine in community settings, and allowing nurses to provide healthcare in community health locations to administer prescribed drugs to patients. Since 2017, Health Canada has invested over $761 million on more than 474 projects across Canada through the SUAP funding, which is intended to provide time-limited funding for nonprofit organizations or other levels of government, Indigenous communities, academia, and other community-led organizations to respond to substance use issues. The projects address the needs of disproportionately impacted populations on a range of substances, including opiates, stimulants, alcohol, cannabis, and tobacco. These are funded projects intended to deliver initiatives covering the spectrum of health. And these include things like prevention, harm reduction, treatment, and recovery. They also support training and capacity development for healthcare professionals in areas such as pain management and guidance on trauma-informed care and anti-stigma care for people living with substance use. And finally, reducing stigma is an important pillar of this work and the action that we have taken federally to improve access to care, including public awareness campaigns and practical tools that for providers to recognize stigma as a barrier to accessing and delivering care. So lots of federal actions across these areas of policy levers that we do have from a federal perspective. From a workforce perspective, there's also work that we're driving. I know it may seem somewhat dated to talk about budget 2024, but a lot of this work is a carryover, as mentioned, because of the general election last year. So there was an investment of $77 million over 4 years, beginning last year, and this was around increasing training for internationally educated health professionals, specifically with some accelerated training and assessment for international medical graduates. There's also an investment of $97 million over 5 years to create a foreign credential recognition action fund. This is led by ESDC, but working with Immigration and Health Canada to look at how we can actually address foreign credential of internationally educated health workers. And then also additional work with IRC, with immigration in terms of their international talent attraction strategy to make the pathway to permanent residency simpler for internationally trained physicians, specifically through the express entry category. Some key milestones in work that has been achieved. One was the funding of a national registry of physicians for the MRAs to have onboarded by this time next year. And we hope that that will actually streamline licensing for physicians and improve labor mobility. We also, in 2023, funded the Nurses NUR-SYS in Canada platform, which is a unique identifier platform for nursing licensure data. And we hope to have the majority of the nursing regulators onboarded by June of this year. And it will be certainly a better means of collecting data, but also will help streamline licensing requirements across the country. And then the Forum of Labor Market Ministers Action Plan is working to address the mobility challenges, and ensuring that we have better free flow of labor across the country. This is a major priority of Prime Minister Carney, and it includes the health professions as well, in supporting that One Canada approach. I would be remiss if I didn't mention this study that we undertook. It was released in January of last year, and it was called Caring for Canadians. And it was a way of actually looking at supply and demand. We worked with StatsCan. We worked with the provinces and territories to actually look at the current supply and projected shortages in keeping with the population growth and aging demography. And you can see there's a significant gap when it comes to all 4 categories of nursing, and a significant gap when it comes to family practitioners as well, and other professionals. So I really urge you to have a look at that Caring for Canadians report. It did get some good press in the Globe and Mail, but we know that there's a lot of work that we need to do to address not just current shortage, but future gap. And some of that is certainly with increased seats and training of health professionals, but some of it also is with evolution in standards of practice and scope of practice. We know that retention is also a key issue. So in 2023, we developed a nursing retention toolkit with nurses from across the country. Because of the current and projected shortages, we know we need to better retain nurses in our current workforce, and that involves structural change in terms of improving the working conditions of nurses. So we released this toolkit in 2024, and it's been really taken up with great enthusiasm from nurses across the country as a bit of a de facto national strategy for nursing. And certainly it was created in the context of interdisciplinary team-based care. We know that nursing doesn't own the retention challenges, that they are certainly interprofessional. And in particular, when you look at the one theme of reduced administrative burden, we know that admin burden is an equal opportunity issue affecting a variety of health professionals. And there is work we are doing from a federal perspective when it comes to looking at federal forms, in particular the disability tax credit form and the burden inherent in that administrative document. So the Nursing Retention Toolkit is another resource, but also I think a strategic reorientation of how we're valuing our health workforce in Canada. We also have noted over years the changes in scopes of practice in terms of who can provide physician equivalent services. And this language of physician equivalent services is what's in the Canada Health Act, which was and so that's the language we use in the Act of 1984. But we've certainly seen the changes in nurse practitioner scope, their ability to diagnose, treat, refer, prescribe, and so on. But not just nurse practitioners. We also know that pharmacists have a key role to play, and they have had massive role expansion. And we know that these expanded scopes also improve access to care, and midwives as well. So one of the things we did was issue an interpretation letter last year. It's called the Canada Health Act Services Policy. This is the 4th interpretation letter that we have issued in the history of the Act. When the Act was approved in Parliament in 1984, it received unanimous approval in the House. And so one of the ways that we keep pace with changes occurring in health care and health professions in Canada is through the issuance of interpretation letters. And this is a way of modernizing modernizing the Act without opening up the Act per se. So the Canada Health Act Services Policy released in January of last year clarifies that patients should not face charges for medically necessary services provided by regulated health professionals if these same services were otherwise covered by a provincial or territorial plan if provided by a physician. So that's the precise language. The implementation date started just on April 1st of this year. Provinces and territories are at various stages of implementation of their compliance with the services policy, and they do need to report on whether patients have faced charges in December of 2028, and then deductions are issued to the Canada Health transfer payments in March of 2029. But certainly it's not our goal to issue deductions. We want to work with jurisdictions to ensure that they can come into compliance. But this is a real notable change in the evolution of the Canada Health Act. So some discussion questions. Some discussion questions that I thought would launch us into the Q&A or discussion section. I'm curious how you break down silos in your clinical practice. I know you do, but I'm curious what that looks like, and how can we leverage these cross-sectoral partnerships. And what I mean by cross-sectoral partnerships is the link between acute care, community care, housing, harm reduction, all of these different sectors in which care is provided, all with the goal of better care for patients, but also improving the way in which the substance use workforce is able to provide care. And what does an integrated health workforce and/or primary care strategy look like in substance use care? So thank you very much, and I look forward to the questions.
Thank you, Leigh. That's a lot to think about. I am again going to invite people to put their questions in the Q&A and also to raise their hand. I hope that I can figure out how to unmute people. I'll start with some of the questions in the chat, and I have a long list of my own. So first question, so kind of going back to the beginning of your talk, was about why your position was left vacant for so long. What you think that it means that it was empty, and for it now to have been filled and filled with you in particular.
So that's a very good question. It was eliminated in 2011 under the Harper government, under an austerity measure that was happening. It was the Deficit Reduction Action Plan at the time. And I mean, I can't speak to why it was eliminated, but I know that was the context in which it was eliminated. I will just mention, though, that it was really the result of a lot of advocacy within the nursing community that led to the reinstatement of the position. So about 70% of countries worldwide have a government chief nursing officer. Often it's combined with midwifery. So government chief nursing officer or government chief nursing midwifery officer, because of the strong parallels between the two professions. And then there was a desire to bring it back, but it took some time, of course, because of the pandemic. And so I think because of my work, certainly it was, it was a job that I applied for. I had the great privilege of doing work with inner city health associates over the course of the pandemic from 2020 to 2022. I was also teaching a health policy course at U of T in the winter of 2022 at the master's level, and that's when the position came up. So I applied, and I think because of my work across sectors over the last 23 years. I've worked in acute care, in community, in academia, um, even camp nursing. I think that, and also in regulation and the professional association. And so that work a lot of it was province-wide and sometimes pan-Canadian. And so I had that policy, I think, expertise and real interest in nursing policy. So it's been uh, a great privilege to be in this role.
I'm going to jump away from the Q&A, but sort of to piggyback on that, you spent a lot of years in clinical nursing, and I know you're very passionate about it. And that led to your graduate work, your regulatory policy and advocacy work. How does it feel to be sitting at this, very high level role? I'm assuming that you're not doing clinical work at the same time. I don't know how you could, but I guess I'm wondering how you sort of feel that you sustain the connection to that clinical work and sustain yourself, because I think it's natural as one gets into more and more senior positions to have to focus in those areas and leave the clinical piece behind, but it's a loss at the same time.
Yeah, it's a good question. I actually get that question a lot. So I was working in a supervised consumption site in the first few months that I started in this role. So I was doing both, and I actually find the clinical work very grounding, being connected to community. It's some of the most rewarding work I've ever done in my career, and still feel like a very strong connection to that community that I had cared for almost a decade. And I think as we sort of pivot into different roles, we derive our satisfaction from work in different ways. And so certainly my connection to the clinical pieces are through nurses. So through that engagement with nurses, nursing students, nursing faculty, nursing executives, leaders across the entire country. And so that's still very grounding for me when I'm able to, visit a healthcare facility, visit a university or college, and really connect with point of care providers. And I still feel a very strong connection to the clinical work. I think regardless of the fact that I'm in a policy role now, I'm still very mindful that all policies, how policies relate to the provider and how they relate to the patient. And I think we can't lose sight of that. But it's also the advantage of being a clinician in a policy role, in thinking always about those two pieces. I'm not a professional bureaucrat, so I think, ensuring that connection to the actual so what of healthcare, the actual clinical practice is a key it's a key lens I think that I bring.
Oh, I think it makes all the difference in the world. That links to a question just for clarification. So you're not a lifetime bureaucrat. There was a question. I know you said you're a federal employee, not appointee, with no connection to a specific officially political party in your role. Correct? Is that?
Absolutely correct. The federal public service is nonpartisan, and so the role is to provide nonpartisan, evidence-based policy advice.
So this takes me back to an earlier question when you were referencing the costs of substance use to our economy overall. And this is a bit of a tricky one, but I know you can manage it. The request was to clarify if it's substance use that contributes to these costs, or the punitive criminalization of people who use drugs and the expensive, and some would say pointless, war on drugs. There's a comment that the slide makes it seem as though it's the people who are using drugs that drive the crisis, when we know that there is also a war on drugs and a toxic drug supply. Issues I know that you're not responsible for in terms of federal and provincial government policies. But I'm hoping that even within your scope, we can talk a little bit about policies and directions and politics.
Yeah, it's a good question. It's certainly not aimed at faulting the individual. It's really intended to look at a structural issue when we look at the burden of disease or burden when it comes to the economics. But it is encompassing all of those things. It is, keeping in mind the enforcement role that the Canadian government also has to play. It's, I think, keeping in mind all of those things. And it probably is an underestimation.
Yeah, and I think from my recollection of where some of those statistics come from, it includes the downstream health effects. So whether it's hospitalizations for coronary artery disease, for traumas, motor vehicle accidents, insurance, underemployment, and all of those things as well. And so there are so many different things rolled into that. And I think you also importantly highlighted that alcohol is a regulated substance and contributes probably the largest proportion to these costs at a national level, right?
Mm-hmm. Yeah. And I mean, I did also start with the personal, and, we'll just note that, there was a month-long coroner's inquest into my brother's death, with many parties represented, 55 recommendations that are, so great cost to the system. And I'm one family, and there's been many inquests into these deaths across the country. So significant cost there as well.
Yeah. Thank you for sharing a little bit about that personal side of your story. I think it's really important to help remind all of us that we don't operate just in these sort of silos of professional and lived experience, that there's so much overlap and blurring.
Mm-hmm.
Do you want to speak to any of the recommendations from that inquest? You don't need to. You offered that opening.
I mean, they're all Googleable. But I think, with the expertise in attendance here, I think it's worth, looking into how many have been adopted since 2018. Yeah, and I mean, there's coroner's inquests that occur in every jurisdiction in this country, and I just really mourn the families having to go through these inquests, because I think there's a lot of insights that we could learn from inquest recommendations, as bleak as that is.
The challenge to us to take a closer look and dig into those. Thank you. A question from Katie Denham, who I know you know and have been in contact with, so this may not be a surprising question. Will there be work towards national licensing for nursing professions to prevent barriers in cross-province and territory care?
So also a question I get a lot. Our goal from a federal perspective, nursing is very complex. In Ontario, there's a single regulator, same as in BC, in Nova Scotia, Prince Edward Island, and Newfoundland. But in other jurisdictions, there's 2 to 3 nursing regulators for the different categories of licensure. So it is very complex. And our goal from a federal perspective is really enhancing labor mobility. So improving that. Improving mobility pathways, essentially for nurses who want to or are licensed in more than one jurisdiction, but also improving the free flow of labor if they so choose to work or locum in another jurisdiction. And so I think the nurses platform that I mentioned will actually help us. It will be an enabler of many things once the regulators are onboarded. Mobility being one, and I think it will improve the integrity of data. It will do a lot of things. So I think, as much as nurses really want a national licensure licensure scheme. We're very far off from that, if that is a goal, because of the provincial and territorial responsibility for regulation. Times the number of regulators that exist. So I think it's fair to say we need to sort of look at what the nurses project goals achieve, and then go from there. I think also we're looking at the National Registry of Physicians into what that looks like. Again, it's a registry, not national licensure. So looking at once all the MRAs are onboarded to that national registry, does that improve mobility? Does that actually improve access and care across jurisdictional borders? So there's lots of work underway in the area of improving mobility, more so I would say than a national scheme for nursing at this time.
I mean, you mentioned really appropriately rural and remote communities that have particular challenges in staffing. And so it makes me wonder whether this increase in mobility will prioritize those underserviced communities rather than simply letting people move from one urban area to another. Not to say that urban areas have all of the services that they need, but what is the thinking to make sure that it's the communities most in need that actually benefit from these processes?
Yeah, and that's always the concern, I think, of jurisdictions. If we are actually enabling mobility pathways, are we going to have an exodus of folks out of rural and remote communities into urban centers? But I do think that there's different strategies that are done across the country to incentivize work in rural and remote communities. With the exception of the very large proportion of the Canadian population that lives close to the US border, in fact, the majority of Canada is rural and remote. So there's great programs, for example, Learn Where You Live programs, decentralized nursing education, speaking to nursing more specifically, because that's my remit. Where nurses are educated in rural and remote communities, and they then want to stay in that community and provide care. And so I think they kind of having a rural and remote strategy goes with also enhancing mobility. I think it's very clear, like even with the climate emergencies that we've seen, that we do have care that traverses jurisdictional borders, and that means that nurses are actually evacuating jurisdictions or health facilities with patients and need immediate licensure in that neighboring jurisdiction. So I think we need to have a rural and remote strategy, as many jurisdictions do, but we can't constrain our workforce as well. We need to kind of ensure that they are able to provide care in the way in which Canadians receive care across borders.
Thanks. Another question from the Q&A. Why do you think that the government usually will decrease nursing staff during budget cuts to save money when our communities are growing and people are sicker and have increased needs as the years go on? Or perhaps you have a different take on that, but that's the question.
Yeah, I mean, I can't speak to the motivations of just like provincial and territorial governments. I think that, it's very clear that nursing is really, as I mentioned, the largest regulated workforce in Canada. Um, and I think, even with my own position, my own current position as chief nursing officer, it's come and gone over the years since 1967. But I know that in austere times, there are changes made um, to essentially models of care, and sometimes that means changes impacting nursing positions. Um, but I think the challenges in healthcare are so significant. We need all hands on deck, and certainly the important role that nursing associations and unions play in advocating for safe, quality care is really key when looking at changes that are occurring in the nursing profession in various jurisdictions.
Thanks. There's a linked question, or a question that sort of connects to your last comment on that, which is that in the physician workforce, there's a tremendous variability in payment models and structures between provinces. Does this apply to nursing? And if so, what are your thoughts on bridging this gap?
Yeah, absolutely the same in the nursing profession. And compensation is something, again, entirely up to the provinces and territories, but this is where the national associations have a key role to play in advocacy. Um, it, it, from my perspective, I would just say it doesn't serve us when we compete for finite resources and limited talent. We actually need to be shifting the narrative to retention. And interestingly, I mentioned the toolkit. We developed that with nurses from across the country. And we didn't mention compensation because nurses believed that when we actually address all of these other things in the work environment in terms of how we're valuing nursing work, whether it comes to mentorship, professional development, reduced admin burdens, safe staffing frameworks, flexible and balanced ways of working, all of those things actually improve the working conditions. And I mean, despite the variability in wages across the country, those are the things that nurses are looking for. They're actually looking for structural change in how we're valuing the essential work that nurses do. So, you know, that's separate from compensation. And I think it really does behoove us to look at some of those all other non-monetary things. Not to say that retention is cost neutral. Certainly it has inherent many costs in supporting retention initiatives, but it is really shifting our focus from this endless cycle of recruitment. We'll always have to recruit as part of ongoing organizational life cycle. But it is also important to look at how we're investing in the workforce that we do have in measures beyond compensation.
Yeah, thank you. Shifting gears a little bit, this is a question on policy and stigma. One of the major challenges being faced today is youth substance. A key model right now to address this is the Icelandic prevention model, which has a key principle of making youth substance use less normalized in society with specific roles for government and legislation and policy. How should the government approach balancing a need for a society that seeks to prevent youth substance use while not promoting stigma towards people who do use substances?
I mean, I would say one of the things that has, I would say there's two responses to that. One is the fact that we still have over $223 million in funded SUAP projects, and that's across 77 active projects, which include a lot of things like mobile clinics, education, youth mental health, and the lock zone, needle distribution pipes, peer support workers, and so on. And we've also seen there has been a youth mental health fund as well that is intended to address sort of that early prevention, as well as the emergency treatment fund. So a lot of these things that we are trying to drive are balancing that prevention, like really still focusing across the demand side, the prevention, harm reduction, treatment, and recovery, and trying to address sort of some of these upstream approaches. Yeah, I mean, I think that there's a lot of work underway, and I think the key areas of work are all still federal priorities, and I think that's maybe one means of addressing ongoing stigma I think it's very complex. It's a challenging question. I'm not sure if I'm totally answering it correctly, but um, yeah, there's the public health, the health, supporting the healthcare workforce, but the public safety perspective as well, and really balancing those is, I think, key to addressing stigma.
I think I heard you mentioning that amongst the priorities that harm reduction supports is still a priority at a federal level.
Yep.
And, we've certainly seen what feel like significant shifts away from harm reduction to some would call treatment focused, or others would call recovery or abstinence focused models of care. So I'm wondering if you can share a little bit about that sort of interaction between, again, federal and provincial priorities, and what you think we might be able to sort of expect or look towards. I might roll into that. I could be incorrect, but I had thought that the previous SUAP funding, that there was discussion about it not being continued, and I know that has been a major source over the last number of years for both research and sort of program initiatives in the area. And I'm not sure whether we're anticipating changes there as well.
So those figures that I provided, the 223 million to provide support to 77 active projects, is as of April 13th of this year, just like a few days ago. But there's no new calls for proposal currently, but those are all active projects that are being funded. And the SUAP is intended to fund innovation and new things that can be scaled. So there's still active funding in those areas that I mentioned. In terms of your question on harm reduction, it does still remain a part of the federal response and the federal priorities. With respect to, I think what you were mentioning is sort of the closure in several jurisdictions. That is really a jurisdictional issue. That is up to the provinces, for better or for worse. It's their decision for the management and administration of healthcare. And so I think, we can't underestimate the role of advocacy in, when things change. But I also think, we need to respect jurisdictional autonomy in developing healthcare as they so see fit for their province or territory. And that's enshrined in the Constitution. So that's really what we have to abide by.
Thanks. I'm trying to balance your answers. I'm looking at the questions coming up. So there's one here that says, and I know this ties into much of what you've been sharing, Leigh, around the federal provincial sort of relationships. Recognizing that the federal government is the transfer payment system for provincial healthcare systems, there is a lack of control over how the funding is implemented at the provincial level. Do you have any comments regarding whether the federal government could intervene when we know decisions made are causing harms and increase the risk of death? For example, provincial closures of safe consumption treatment sites.
Yeah, it's a good question. It's another question I get a lot. And so those agreements of the transfer payments, those are with the bilateral agreements that are made for the federal government to individual provinces and territories. Those agreements are made at the elected official side. So the elected, the ministers of health, if you will. And so when the Working Together for Canadians agreements were made, that's the most recent agreement, a few years ago, the individual provinces and territories had to agree to a set of mutual priorities that they would be advancing when it comes to health workforce. And some included mental health and addictions in that. But again, it's up to the jurisdiction to choose. So, the federal government has power over the Canada Health Act, as I mentioned. So when there's violations of the Act, when patients are charged for physician equivalent medically necessary services, we do have spending power, if you will, in upholding the Act. But in terms of federal transfers, it still is up to the jurisdictional autonomy, the jurisdictions, the provinces and territories, to determine how healthcare decisions are made. So, the example of Ontario with the closure of supervised consumption sites, the provincial government has also funded heart hubs. And so from a federal perspective, we have to respect that. Federally, we provide the exemption under the Controlled Drugs and Substances Act, but the province provides the funding and approval of those sites as well at the provincial level. So this is kind of how we work together, if you will.
Mhm. Another question from a participant who says, I heard you say that a lot of Indigenous and Black people have high demographics of substance use. Is there any federal response with respect to cultural sensitivity for these two groups?
So there's work in different areas that I can't speak to specifically, but I know Indigenous Services Canada has direct responsibility for health care delivery in Indigenous communities, mainly south of 60, but also funds a lot of programs in Indigenous communities across the country. Including substance use care services. The Public Health Agency of Canada also does a lot of work on anti-racism initiatives and anti-discrimination. And so those are kind of two good sources for that culturally sensitive information and interventions.
Thanks. There is a question about whether there's an equivalent position in government to yours for physicians. And I think I know the answer, that there's a chief public health officer, but not, those roles are different. Anyway, I'll let you answer that part of the question first. And then I'm really curious about how you in your role and office interacts with the chief of physicians and Public Health Agency of Canada.
Yeah, so the public health, maybe I'll answer the last part first. The Public Health Agency of Canada is linked to Health Canada, so we do work closely together, but it is a separate agency that was established. And so, yes, we have a new Chief Public Health Officer as of April 1st. We also have a Chief Medical Officer within Health Canada, Dr. Supriya Sharma. So a lot of her role is well, I can't speak to her role, but it's very vast around regulation and so on. She's often, testifying at parliamentary committees or at various things. So we do have a chief medical officer, we have a chief dental officer, a chief science officer. So yes, there are analogous roles, and we do meet as officers and advisors often to look at how we're providing evidence-based advice in our respective roles.
Yeah, I'd love to be a fly on the wall in that. Thank you for answering and for clarifying that. I'm moving to Ontario, and this is a question about nurse practitioners. So I know that it's not under your current jurisdiction, but you have lots of experience here with regulation. One of the barriers that continues to be an issue for nurse practitioners is their inability to implement a Form 1. Do you have any thoughts on whether that might change?
That is a very interesting question, because I had actually forgotten about that piece. I know one of the few things nurse practitioners can't do is order a nuclear medicine test, but I had forgotten about that piece, the Form 1. That would be a great question for the Nurse Practitioners Association of Ontario. They're leading a lot of the advocacy efforts and would probably have a good grasp of where things are at. with respect to that? It's a good question, and I'm glad it was raised and it's on my
Yes.
radar.
Thank you. So it's now back on your radar, and to be carried forward.
Yeah.
I think I have covered the questions that were in the Q&A. I don't see anyone having raised their hand. You have another moment if you'd like to. I guess just as a last question, you talked about so many challenges that are being faced across our system with increasing complexity, which is related to so many factors. And that substance use is so intertwined, right? As you said, the person with knee replacement, the person having a baby. How do we ensure that with so many competing demands that substance use is not dismissed as being something that is extra? So thinking about healthcare provider education, stigma education, and then, other levers to ensure that this is no longer something that is on the sidelines where people are afraid to raise it, afraid that, they will be dismissed for it, and that across our teams working together, we can really ensure that it continues to be addressed as really as a determinant of health in so many ways.
Yeah, I mean, I think so what we've talked a lot about today has been the workforce. But of course, it sort of bleeds into the health systems in our country and how they're established. And in most jurisdictions, acute care gets the majority of dollars when it comes to health spending. Often 70% of provincial, I will say provincial budgets more so than territorial because the territories are a bit different in terms of their geography and the way in which they structure healthcare. But in most provinces, acute care gets about 70%. Yet, with the exception of RAM clinics and addiction consult services and integrated substance use care where it exists, it isn't something that we've seen proliferate throughout acute care. And I do think, just because of the way in which funding dollars are spent, like there's always going to be a need for hospitals. We do still need to reorient the systems to focus more on upstream community, public health, and primary care. But given the current system, I know the tone work was really trying to focus on that acute care piece. And I think more work is needed in that area to ensure that, when people do come in to hospital with an overdose, that they're not, discharged without any resources. And I know I'm saying that given, extreme constraints within the acute care sector. But I do think, health workers can really be a bridge across these disparate parts of the system and do a lot of this MacGyvering, invisible work. So, both are needed, enhancing education, but also really looking at the levers and the way in which healthcare is organized in the various jurisdictions. I also think, we can't underestimate the power of a therapeutic relationship and how that can transcend a lot of these silos in helping patients navigate a very complex system. I mean, everyone attending here today is a champion for this patient population, and they need to spread their wealth of expertise as much as possible because all of that does help break down stigma as well. I mean, I think, and we can't underestimate the importance of advocacy as well. We always advocate, at the point of care, but we also can advocate for structural and systemic change. And I think that goes a long way to making a difference for the lives of people we care for.
Thank you for closing on that. I think and agree with everything you've said, and that we need a system where we're not MacGyvering the care for people who use substances and that aspect of their care, where that is
Yeah.
acknowledged and formalized and supported as part of the care package and pathway.
Yeah, agree.
Thank you very, very much for joining us, for your time, for coming back this year when last year was derailed, not through any fault or choice of your own, and for giving us a lens into all of the different sort of levels and systems at which some of these issues and conversations are taking place, which I think is a bit of a challenge to all of us to think about, as you said, the different levels and places where we can be advocates and try to make changes and continue to, ground that in our clinical experience. That is the grounding, as you said, but we have opportunities to expand that through the relationships and through other levers. So thank you very, very much for sharing your experience, your wisdom, and a little bit of your personal story and passion. And with gratitude, have a great rest of your day, whether you're continuing with us or not. For everyone else who is part of the conference, we have a fairly short break until 10:45, but stretch, enjoy it. I did not put an evaluation in the chat. I apologize. We'll try to make sure that gets to everybody. That stretches my multitasking skills. Thank you, Sarah. And we will see you all shortly. Thanks so much.